Chairman, ladies and gentlemen, I'll start my talk by thanking my colleagues Franco Cecchi and Yacoub Olivotto, who did a major job in organizing this extremely enjoyable meeting with a lot of new and exciting data. My talk relates to bridge to transplantation and mechanisms of heart failure. And the enigma of heart failure has been that we all know that there is now a global epidemic of massive proportions, which is increasing, and I could supply a lot of data on that. It carries poor prognosis in its severe form, which is worse than cancer or any other disease, with a major source of disability and death, huge financial burden, both to the individuals, the countries, and all involved. It has been defined and redefined, but always mostly as a syndrome. And therefore, the treatment has been, up till now, largely palliative. And we do not have a specific or curative treatment. This can only change by understanding the basic mechanisms, which, again, have been kept a secret, if you like. Who holds the secret? If we look at the pathogenesis of heart failure, it is obviously related to the heart, and there are structural and functional changes which are collectively called remodeling. There is an important role, as we all know, of the vascular coupling and the neurohumoral elements. What's the potential for myocardial recovery? Because we firmly believe that bridge to transplantation using left ventricular assist devices does hold the secrets of heart failure. So what's the potential for myocardial recovery? Well, up till now, conventional wisdom has it that remodeling is relentless, with minor temporary remissions and exacerbation. Few recent drug trials showed evidence of definite reverse remodeling. However, it was the bridge to recovery using left ventricular assist devices, which was for the first time being shown in some patients to produce near complete, if not complete, recovery, with the possibility of removing the left ventricular assist devices. I submit that this presents unprecedented opportunities to unravel the secrets of heart failure at organ level, but also importantly at cellular and molecular levels. Now, who are the major players? We really have to identify these if we are going to make progress. And obviously, the contractile cell, the myocytes, the microvasculature, and we had the brilliant talks, Paolo Camici. The fibroblasts, which up till now were thought of as just an observer cells, if you like, and just filling in when there is damage. We know now, differently, that they do play a major role. and they are at least as active as the endothelial cell in being secreting paracrine factors, in responding, and modifying the matrix, which is a major source of educating or having a two-way communication with the myocytes. We know that there are mechanoreceptors, and the chemical and biomechanical characteristics of the matrix is a major determinant of myocardial function. Now, I will not bore you with too much details, but if you look at the myocardial cell alone, you find that there are so many changes associated with recovery. These starting with size and shape, more about that. Cytoskeletal proteins, and we had a lot about sarcomeric, but also non-sarcomeric proteins change massively during recovery. There are integrins and linker proteins which actually govern cell biomechanics. And our group have been very interested in that, not only in the myocardium, but in valve interstitial cells, where we now learn that molecules like filamin A play a major role in the biomechanics of the valve cells and are implicated in mitral regurgitation, for example. The same applies to the myocardium. Adrenergic receptors that have been known for a long time to change during heart failure and indeed during recovery. And also the pathways like G proteins, cytokines, and cytokine expression, because the cytokine theory had it for a long time that the cytokines are produced somewhere else, and it's leakage in the gastrointestinal tract, which allows the cytokines to affect the heart, particularly the pro-inflammatory. We now know that this is generated in the heart itself, and that activation of both the innate immune system and the adaptive play a major role in both the progression and regression of the heart. I don't need to tell you about calcium handling proteins, and Dr. Krania is in the audience, I can see. And we know that these cells and electromechanical coupling is of very great importance. And we have shown that in the recovery program, that this is, and we've heard a lot about sarcoplasmic reticulum calcium and what happens. T-tubules are also a major player, and Michael Ibrahim in our group and many other people have shown that changes in the T-tubules are key and are early in both heart failure, and importantly, they are reversible. But how? In a minute, I'll show you. We've heard the brilliant preceding talk about survival factors, apoptosis, and autophagy. Fantastic work. Congratulations. But that also plays an important role in both progression and regression of heart failure. Interestingly, if you look at cardiomyocytes, in this case, this is obtained from donor hearts at the time of transplantation. They are normal. During heart failure, they're huge, and they change their shape as well. Interestingly, that can be reversible. And this is the same patient following recovery. However, at one time, it was thought that this regression in the massive enlargement in myocardial cells always means recovery. Not so. It has to be associated with electromechanical or changes in calcium handling proteins. You can measure the myocytes either on single cells like I've shown you, or by looking at conductance. The end result is the same. But interestingly, if you just look at a biopsy from a patient at the time of insertion of the left ventricular assist device and at the time of recovery, you see massive changes in the myocardium. You can see that the size of the cells are much smaller, but there is now several studies showing that there are also changes, but you can see that for yourself. There are changes in the nuclei, suggesting that there is a degree of proliferation. How does that happen? Well, that needs further studies, but our group, for example, showed that there is increased expression of IGF-1, Paul Barton, and that the IGF-1 is related to STF1, that there could be cells coming from somewhere else as well, progenitor cells. How many of these cells are the same and have recovered, and how many are progenitor cells? That's another question which is currently being investigated. So the progenitor cells could be resident progenitor cells proliferating, or recruited progenitor cells, as I mentioned, with STF1. I mentioned earlier the importance of sarcoma. We've seen slides like that many times in this meeting, and the important thing, players with the sarcomeric proteins, but in the recovery program, and this study was performed by Emma Burks in our group, there was a lot of changes in both the non-sarcomeric cytoskeletal proteins, some in the sarcomeric proteins, but importantly, others in the linker proteins and the ion channels. Now, I'm talking about the ion channels. All these are studies which has shown changes during recovery in the ion channels, and particularly we were quite interested and intrigued to show that sarcoplasmic reticulum calcium content actually was key to recovery, and that has a lot of implication in inducing more recovery. Changes in gene expression have been looked at by looking at target genes, specific pathways, but also as fishing expeditions by many groups, including ours, and yielded a fairly important and interesting information. What are we currently looking at? Serum biomarkers, as well as the proteomics of paired specimens from human samples, as well as in experimental models, mainly in murine models. And now we are starting to look at large animal models as well. Now, the unloading is really intriguing in itself, because we have heard from the previous speaker that the stress and mechanoreceptors are really important in induction of heart failure as well as progression. And the opposite is true. is that unloading can produce reverse remodeling with improvement in function as well as structural changes. The problem is that this is a double-edged sword, if you like, because if excessive, either in time or degree, it can lead to the opposite, and that is atrophy. And we've done some work in animal models which show that quite clearly. And there is evidence in humans as well that it is phased. This was the reason why we thought that combination therapy is really important. And combination therapy consists of induction of maximal reverse remodeling by the LVAD and pharmacologic agents which are known to produce reverse remodeling, followed by induction of physiologic hypertrophy using a variety of strategies, where these strategies have been combining unloading as a platform for pharmacologic agents, and we have used clenbuterol, a beta-2 agonist, which has been used to induce skeletal hypertrophy, and in many experimental studies, it's been shown that it also produces a degree of physiologic hypertrophy in the myocardium, but the combination with unloading seems to be quite interesting. And more recently, we've been using ivabradine in both experimental models and indeed in some of the clinical trials, like the SHIFT trial. It was shown that ivabradine does not only reduce heart rate, but it produces reverse remodeling, and that's in humans. And in our experimental model, this was quite independent of its effect on heart rate. And that's quite an interesting thing. Recently in Doha, we have patients who have been going along with a HeartMate 2 for nearly 3.5 years with no evidence of recovery whatsoever. And we decided that we will try and induce recovery, and with a program of both rehabilitation, but importantly ivabradine, my colleagues in Doha have shown that there has been dramatic improvement in heart function. And this is documented and will be reported soon. And the cardiologists involved are here in the audience. One thing about this is also it showed what we always suspected, that although heart failure is characterized by contractile dysfunction and dilatation, but now we know that those two processes are not always associated. For example, in this particular patient, the contractile dysfunction is so much better, but the heart continues to be large. And that is similar, you might say, but the opposite is that you can get heart failure with preserved systolic function. So heart failure, the contractile element, whether it is systolic or diastolic, can be independent of the dilatation. That needs to be studied further. We're quite intrigued, for example, by the capacity of some species like the zebrafish or the salamander to have a high degree of regeneration, you can cut half the heart and it grows it again. We think that could be a function of unloading, because the pressure in these animals is extremely low. Furthermore, there has been some recent studies from Eric Olson and Hisham Sadeh, which published in Science, showing that neonatal hearts with a very low pressure have an incredible, I mean, that's in mammalian heart, that was done on mice, have a great degree of capacity to regenerate. So the unloading in itself can be a platform for regeneration, but it could be aided by gene therapy. And we do have now, after gene therapy has been living under a cloud for a long time, and the reason was that we didn't have very good vectors, neither did we have a good molecules. Now this is getting better, that we do have effective vectors which are cardiotropic, but also trials with SERCA2 and more recently STF1. And I know that Professor Krania is working on other molecules. Cell therapy in combination with unloading could have, and that has not been shown as yet, but it does make sense that the cells have a higher chance of surviving if the heart is unloaded and going at a slower heart rate. Interestingly, our group have been very interested for some time in nanofibers and carrier molecules, both on their own, but also these carrier molecules like micelles, and you can have interesting molecules to induce recovery, but also in tissue engineering using designer scaffold. And the designer scaffolds, now there are many innovative ideas. They can be biomimetic using organic molecules, which is limiting. Now we have a young researcher who's working with us in Qatar, who is working on nanofibers and scaffolds from the entire periodic table, particularly metals, to produce cages and designer scaffolds. Obviously, it's the early time to know what's happening, but we, as I mentioned earlier, the extracellular matrix holds an important key to the behavior of the cells. And as a matter of fact, we've been working with that, Ches Terracciano in our group, with Chris Rao, the PhD student. And what Chris did was lining iPS-derived cardiomyocytes. On their own, they really did not behave like cardiomyocytes, either electrophysiologically, but importantly, in gene expression. However, when put on a scaffold with grooves, they lined up and behaved a lot more like true ventricular cardiomyocytes. Again, early work, but it shows that the importance of designer scaffolds in inducing more effective behavior in cells, which could be used in combination therapy using left ventricular assist devices. So where do we go from here? In an editorial recently published from our group, we called Bridge to Recovery and the Search for Decision Nodes. What does that mean? That we really do need to put all the findings I've been talking about into perspective. And we now know from the concept of complex networks, and that these networks could be electrical, relatively simple but still complex, social, maybe slightly more complex, biological, very complex. However, what these theories say that there are nodes in all these complex networks, and the nodes can vary in size, but they communicate in a bidirectional fashion all the time. Some of the hub nodes, which are so obvious, are actually not the decision nodes. And the hidden node somewhere holds the key, and that is what we're searching for, the decision nodes. That's what we think. That's actually system biology using complex networks. Because if you're faced with thousands, millions of changes in the environment, I think it would be very difficult to control that with a single broom like this child is trying to do. It's more appropriate to define the complex nodes and go from there. So in conclusion, I think that bridge to recovery using left ventricular assist devices offers unprecedented opportunities for deciphering the secrets of heart failure with the promise of discovering new therapeutic targets and specific therapies. Thank you.
Thank you so much for this nice, informative presentation. And as you mentioned in your presentation, yes, the bridge to recovery, the LVAD, adding on top of it the ivabradine and the other pharmacological agents, got the preliminary results are promising. But my concern is regarding as a bridge to transplant. Do you think that a certain LVAD will be better than the other regarding surgical, like in the surgery of transplant, will be less complication, and also regarding immune system will be less or better to less sensitization for the immune system that we can use as a bridge to transplant?
You've asked many questions now. The first is, in the case of this particular patient, we are really hoping not to bridge for transplantation, we're bridging for recovery, which is sustained, and we have patients like that at have here who are now 5 years with no problems. With regard to your question, it's an excellent question. Which type of VAD produces what sort of damage? And like what Professor Cecchi was saying, it's a great thing, but at what price? When he was talking about devices. And the same with LVADs, there is a price. While the pulsatile devices induced recovery a lot better, and also did not require anticoagulation except aspirin, antiplatelet. They had massive number of complications, mechanical complications, and within 18 months was just unacceptable, especially related to the valve. So the constant flow devices came in, smaller, more durable, one moving part, no valves, and particularly the HeartMate 2. And then we have the hardware, and there are more smaller one, the cellulite, and circulite, I should say. And all that really are quite exciting. And indeed, in the last trial, more than 90% of patients, just 90, 91%, survived for more than 6 months or were bridged to transplantation. So that's fantastic. But your question is, at what price? There is a price. The constant flow, to everybody's surprise, did not produce as much organ damage. But we studied the effect on the coronary circulation, on the aortic valve, and now there is still thromboembolism in spite of anticoagulation with antiplatelets. And worryingly, there is also bleeding, gastrointestinal bleeding, due to abnormalities of von Willebrand factor. But all said, these devices, you still have a survival of more than 90% in patients who were moribund, and now new trials are being started saying that we should not operate on the extremely sick patients, the Intermax 1, 2, and 3. Just leave them alone and apply the device to better. So there is a price to pay, but currently it's looking sort of affordable. Have I answered your question?
Take the occasion of your competence to ask you a question about ivabradine. You say that ivabradine could have an effect on remodeling not related to the heart rate reduction. So since we have some data on that and we published, I would like to know your opinion. What could be the mechanism? The pacemaker current which has been overexpressed in the failing heart and the ventricular myocyte, or something else?
I honestly don't know. I think you're stretching my imagination now. And the data we have, and there has been other data in the literature showing that it's independent of the heart rate reduction. That if you fix the heart rate, and if you look at dependence as well, it is an independent. Now you ask me, what is the mechanism? I mean, it could be one of all these many nodes I have shown you, and perhaps you can decipher some of that. Thank you for the question, anyway.
Any other questions? I have a very last question.
Okay.
So is there any, so you mentioned that some patients recover, not all of them. What are the predictors?
Yet another fantastic question. I think we don't know, again, and in our series, which was published in New England Journal of Medicine, you might have seen that, 70% of the patients recovered, but we did stick to non-ischemic cardiomyopathy. So all these patients had no coronary artery disease. We think that you might apply it there. A large number, even at that time, which is, I'm going back 12, 15 years, actually did have a familial incident. Some were advanced postpartum, and their rate of recovery was just as good as anybody else. So it was not a contraindication, but we still could recover 70% of the patients, whether they had familial or not, whether they had toxic effect on the myocardium. We had also patients post drugs for malignancy, and they just, these were not contraindications for some reason. So it shows you that we don't know some. Age was another one. Time that we thought that only the younger patients will recover. Not so. Patients in their 50s and 60s did recover just as well as the young patients, the same ratio. So I think we do not know the answer to your question.